My name is Beth Feynman. I am one of the co-chairs, and I am joined with Dr. Joseph Terriman, who is an assistant professor of nursing at DePaul University in Chicago, Illinois. Also joined by us is Donna Cantamero, who is a nurse practitioner and a myeloma specialist at Mount Sinai Medical Center in New York City. Tiffany Richards is also joined by us, and she is a nurse practitioner and myeloma specialist at MD Anderson Cancer Center. The International Myeloma Foundation is sponsoring the symposium, and we are so fortunate to all be part of their Nurse Leadership Board, which is our 10th year. The International Myeloma Foundation also has the International Myeloma Working Group, who has the scientific community makes recommendations for the management of myeloma. We'll talk about the Black Swan Research Project and other publications and brochures. In your packets, we have evaluation forms. You must fill out your evaluation form in order to get CE credit. We also have a copy of our most recent supplement by the Journal of the Advanced Practitioner in Oncology, was just published, and it is a real great resource. We also have a jump drive in most of your pockets, and the jump drive will include all of the publications. You also will have a form to fill out for free resources to be mailed to you and your cancer center to give to patients. This slide outlines our agenda. We're to start at 12:10 to 12:15 with this program, and we're almost finished with the welcomes. We'll also focus on several case studies to reinforce your understanding of multiple myeloma. Learning objectives are very important. We'd like to achieve all of these learning objectives. As a result of this program, we'd like to identify newly approved therapies in combination for multiple myeloma, apply best practices in the management of multiple myeloma patients receiving these new therapies, discuss survivorship. Survivors of myeloma are from the diagnosis and throughout. We want to enhance their understanding as well as yours, and express the key role nurses play in advocating for myeloma patients and caregivers. I would like to kindly turn the mic over to Dr. Joseph Terriman, who's going to start with our first case study and a background of multiple myeloma. Joseph?
Thank you, Beth. Good afternoon, everyone. So let's begin with a definition of multiple myeloma. Unlike breast cancer, I think most of the patients will know what breast cancer is all about. But when a patient's diagnosed with multiple myeloma, oftentimes the patient would say, "What is multiple myeloma? I haven't heard of it." And so it is important that we go to the basics when it comes to informing our patient about the diagnosis. And the two key words for this would be plasma cells. So multiple myeloma is a cancer of the plasma cells. And then you can follow up your education with, and the plasma cells are responsible in producing immunoglobulins or antibody to fight off foreign antigen. So what happens in multiple myeloma is that one copy of plasma cells proliferates in an uncontrolled manner and then produces the same immunoglobulin. As you can see in your slide there, the most common type of multiple myeloma is IgG myeloma, about 65%, and about 20% is IgA, followed by the IgM, but that's also very rare. The other rare myeloma are the IgD, IgE, and then the non-circulatory multiple myeloma. The common test that we use in order to detect or confirm multiple myeloma is the presence of monoclonal protein, or what we call M-spike. There's so many names, sometimes we also call it paraprotein, M-protein, just to confuse our patient. No, I'm just kidding. So, those are the different terms, myeloma protein, M-protein, paraprotein, M-spike. There you go. No more secrets. So, to diagnose multiple myeloma, the patient must have one of the CRAB symptoms. But recently, in 2014, the International Myeloma Working Group actually updated the diagnostic criteria for active multiple myeloma. So aside from CRAB, which stands for calcium elevation, renal insufficiency, A for anemia, and B for bone lytic lesions, they added three items. The first one is bone marrow plasmacytosis, and that is a monoclonal plasmacytosis greater than 60%, and the serum free light chain ratio to be above 100. And then the last one is the MRI, if there's a presence of a focal lesion in a myeloma protocol MRI. Multiple myeloma actually has a pre-malignant condition, and it's known as MGUS or MGUS, monoclonal gammopathy of undetermined significance. 99% of multiple myeloma is actually preceded by MGUS. What we know is that over several years, MGUS will slowly develop into multiple myeloma and then into malignant or active multiple myeloma, with a caveat that there are some patients where the MGUS will never ever reach a point of malignancy. So there are hallmarks for the different stages of the development of multiple myeloma. So in the MGUS, the patient's definitely not having any symptoms. There are no myeloma-defining event either, and then the chance of progression is just 1% per year. Whereas in smoldering multiple myeloma, the bone marrow plasma cell is slightly higher. It's at least up to 10%. And then there's still no myeloma-defining events, and then there's also no CRAB. And then the last one there is that there's no need for treatment for both MGUS and smoldering multiple myeloma, except for the ultra high risk. Those are the terms that Dr. Mateos used in the publication in New England Journal of Medicine. The ultra high risk smoldering multiple myeloma are now being considered for early treatment in the context of clinical trial. As you can see in the farther right, you can see there that the active multiple myeloma definitely has a lot of disease features. There's CRAB, and there's also a myeloma-defining event as added by the International Myeloma Working Group. And then, again, there's no more likelihood for progression because it's already active disease, and the patient definitely needs treatment.
So as I mentioned in the beginning, 2015 was an amazing year for advances in multiple myeloma. As you can see on this slide, the melphalan and prednisone-containing regimens were the first treatments in 1958 and then 1962 for multiple myeloma, regimens that you'll see we still use today. What we saw in the 2000s was an explosion of new therapies. We never thought cure was possible, but we'll talk about the Black Swan Research Initiative by the International Myeloma Foundation, and you'll see that cure is now a possibility for patients. The new drugs that were approved in 2015 are antibodies, daratumumab and elotuzumab, a proteasome inhibitor, which is a MIB, which is ixazomib, and then an HDAC inhibitor, histone deacetylase inhibitor, called panobinostat. We also have several new indications, which we'll talk about as well. As you can see the different colors on this slide, and again, you'll have access to all the slides either online or in your jump drive, you'll see we're looking at drug classes now because we have so many drugs that we're mixing and matching. We have to think of them as terms of drug classes, which we'll talk about.
We'd like to start with our first case, and that is Oscar. He is a 63-year-old golf course manager. He is quite active physically and actually has no comorbidities. He was found to have abnormal blood counts and was referred to a hem-onc clinic for further evaluation. So the workup for Oscar showed that there are abnormal lab tests, and I just want to highlight the myeloma-specific abnormal labs. For example, the creatinine of 2.1, the hemoglobin slightly anemic at 10.5, and then the kappa lambda right chain ratio is 185. So think about the myeloma-defining event. And then the patient has bone marrow plasmacytosis, and that is a monoclonal plasmacytosis with 70% kappa-restricted cells. And the cytogenetic is normal with 23 pairs of XY chromosomes. The MRI of the patient showed some focal lesions, and then the skeletal survey also showed multiple lytic lesions. So with this presentation, the patient's been diagnosed with active multiple myeloma.
So we saw how Oscar presented with multiple myeloma, but how do other patients commonly present? Well, we know that severe back and bone pain is a hallmark of multiple myeloma, and about 58% will experience back pain, which prompts the diagnosis. Individuals will also present in renal failure. Maybe it's a gradual change in the urinary pattern, or it's an acute renal failure requiring hospitalization. Other medical emergencies which require emergent treatment might also shed light to a myeloma diagnosis. An individual who's in an automobile accident then goes for x-rays, and then lytic lesions are seen on film. So these are all ways that people can present to your clinics. During routine physical exam in patients with little or no symptoms, these can also prompt the diagnosis based on abnormal routine blood work. There are many top choices for newly diagnosed multiple myeloma patients, and I'd like to underscore the importance of a clinical trial. We know many standard of care FDA-approved therapies include imide-based, which are lenalidomide, pomalidomide, and thalidomide. Although pomalidomide is not yet approved for upfront use, it is used in clinical trials. Your MIBS-based, which is proteasome inhibitors such as bortezomib, carfilzomib, and ixazomib, again, some of those in clinical trials, as well as mixing and matching the regimens. So I mentioned before, the clinical trials have not, without them, they haven't gotten us to where we are. So we need to find and seek out for our patients like Oscar, who might have a little more time to make that decision as well.
So when it comes to decision making, this is a model that shows the evidence-based medicine, or we can also call it evidence-based nursing. And there are three elements in this decision-making model that shows you the data from research, the clinical experience of the clinician, and the patient preferences should be weighed on and into making a treatment decision. It is critical that we as nurses will gather information from the patient, especially the contextual factors of the patient, because patients give us a lot of information during clinic visits, during infusion time, and all other times that they interact with the nurse. We actually serve a lot of purpose when it comes to becoming an informant for the multidisciplinary team, so that we can truly bring the perspective of the patient and consider the patient preference in the decision-making process. This is a model on collaborative practice. As you can see, the patient is the center of the care, and there are many practitioners that are contributing to the overall outcome of the patient. And it's important that in a multidisciplinary team, we as the nurse can do a lot of roles, including informant, assessment, patient education, advocacy, making sure that the patient's voices are heard when it comes to treatment decision making.
As Joseph mentioned, there are so many different parts to that role, and nurses, advanced practice providers, and all of us can play a role. But we also think about how fit is the patient. So when we're thinking about what types of treatment to recommend, like Oscar, he's pretty healthy and active, and so we want to make sure that we can maximize his lifespan as best as possible and quality of life. Is the patient, like Oscar, eligible for a stem cell transplant, and what's the length of therapy? We'll share with you information on research which shows the longer individuals with multiple myeloma are on a therapy, regardless of therapy, they tend to do better for long terms. I'm going to focus on what we think about with patients with prior therapy in a future slide. Oscar would be considered a transplant candidate. So the types of transplant that are typically performed in patients with multiple myeloma would be autologous stem cell transplantation. That is considered a standard of care. In many institutions or centers, the individual receives 4 or 6 cycles of therapy, go through a consolidation period with the high-dose melphalan or similar therapy, and then in a maintenance phase. So that's kind of what it looks like. There are several studies which show that autologous stem cell transplant with lenalidomide or proteasome inhibitor, in some studies, maintenance makes a difference. We do know a recent study which was published at the American Society of Hematology showed that 3-drug induction with lenalidomide, bortezomib, and dexamethasone, then followed by maintenance, showed an improved progression-free survival, meaning patients were in remission longer when they had bortezomib included in that regimen. So we're going to watch for new and evolving data, but the take-home point is, if your patient is a candidate for stem cell transplantation, we should give them the treatment options based on the information and let them decide whether or not they want to be part of that process. This slide is intended to educate you on some of the terms that we'll be using. It different parts today, and it focuses on biomarkers and genomics in multiple myeloma. Many of our cancers have biomarkers. A biomarker is a characteristic that can be used to objectively measure disease. Think of a hemoglobin as it measures anemia in your individual patient. We have biomarkers such as SPEP and UPEP that Joseph mentioned that are specific to multiple myeloma. I think it's important for nurses to know what kind of myeloma your patient has. Is it IgG kappa? Is it lambda light chain? Because we're going to monitor the disease as they go on, as we'll see in the next slide. Genomics is the study of genes and their characteristics as well. There are different genetic markers in various cancers and other diseases that we need to objectively look at to say, does that individual have a high risk or a low risk, or should we be treating them differently? Kind of trying to personalize medicine. The biomarkers in genomics, I think, are critical in monitoring of the disease. This slide represents the International Myeloma Working Group, which is a subset of the IMF, and the myeloma response criteria. So when your patient, like Oscar, comes into the clinic and they're diagnosed with multiple myeloma, they're gonna ask you, how are you know that the treatment's working? Well, we have different remission categories. So the first one I like to point out is a PR, or a partial response. That's when the individual gets a 50% reduction in the paraprotein in their blood or urine, wherever it's measured. A VGPR is a little bit better. That's a 90% reduction in the paraprotein. So think of your patient as having an M spike of 5.0 grams when they come to you at the beginning, and then now it's down by 90%. You can say, gosh, that's a very good partial response. Many studies show that people do better when you have a deeper response, such as that VGPR. Now, a complete response is when you have no evidence on immunofixation of a paraprotein in the blood or the urine, and we also have a bone marrow that's negative. We have newer molecular techniques that are shown on this slide. This slide is showing you the concept of minimal residual disease testing. This is genetic testing that's done most effectively. It can be done in the blood, but most of the time in the bone marrow. So what we're looking at on this slide, focus on the downward curve. So at the beginning, at the top is when that individual presents with multiple myeloma, and at the end of therapy, want to be as deep as possible. This is a theoretical model from published last year in 2015 by Spanish investigators that showed the deeper the response, the longer the remission in most people. So cure was not possible years ago, and now we have these drugs that are eliminating proteins from the blood and the urine. And we want to hopefully do more research to find out better ways to use the drugs we have as well.
So while your patient is on treatment, it's important that we check adherence to treatment. And our patients actually will get either injectable or an oral agent. It's very important that we understand adherence because there are so many things that could factor into the success of the treatment. The first one is about patient factors. Patient can have so many things going on in their lives and could contribute to their non-adherence to the selection or to their taking the medication. There are also other issues such as lack of confidence, other issues, economic issues, and then on the other side of your slides are the health system factors. These are really important because understanding all these factors together could better serve the patient and eventually remove some of the barriers that could lead to non-adherence. Our role as well as the nurses are really essential in the success of the treatment for patients with multiple myeloma. Make sure that we reinforce the rationale for treating the patient. Make sure that you provide brochure, and you also give important telephone numbers that the patient can call during emergencies. It's important that the patient will show up during clinic appointments, especially for the IV drug appointment, and the appropriate schedule between doses of the drug. Provide tools and other educational materials, and involve the caregivers as well, because it's really important that the caregiver is involved so that the patient will be successful with the treatment. So Oscar actually considered clinical trials, but decided on 3 drug regimen. That's the lenalidomide, bortezomib, and dexamethasone. He had a stem cell collection and then went on to autologous stem cell transplantation, and then followed by a lenalidomide maintenance. He had a supportive agent such as zoledronic acid for the multiple lytic lesion that was found at the time of diagnosis. While on bortezomib, lenalidomide, dexamethasone treatment, he was on acyclovir because patients who are on bortezomib actually has about 10% chance of having shingles while on active therapy. Aspirin is also included in the regimen to make sure that the patient doesn't develop deep vein thrombosis due to the combination of lenalidomide and dexamethasone.
As Joseph mentioned, Oscar was already protected with blood clots. This slide highlights some other factors that you would consider as a nurse if your patient is taking this 3-drug combination, which is very commonly given at myeloma today. Lenalidomide, as Joseph mentioned, we worry about pregnancy prevention. It's this REMS, the Risk Evaluation and Mitigation Strategy Program, so that the patient doesn't get anybody pregnant or become pregnant themselves, as well as risk stratifying. So blood clots are a really big issue in patients with multiple myeloma. It's an inheritably coagulable state. So we want to make sure that if they're smoking cigarettes, they have a high body mass index, they have cardiac or renal disease, that they might require short-term at least prevention for blood clots as well. Bortezomib can be given subcutaneously. A recent study showed, actually it's not as recent anymore, but in 2010 we saw a study that was published by Moreau and colleagues that showed that subcutaneous administration of bortezomib decreases peripheral neuropathy and GI effects as well as some other things such as hypotension. So we urge you, if you are having a patient in the clinic receiving bortezomib, that it be given in a subcutaneous format. We use an air sandwich technique, which you put a little bit of air behind the solution and with a fresh needle and injecting the medication into the subcutaneous tissue, such as the abdomen or the thigh. That will decrease your chance of having an injection site reaction from bortezomib. Dexamethasone can cause a whole host of side effects from mood swings to hyperglycemia. It's important to screen your patients. Do you have a history of psychiatric illness? Have you ever had hyperglycemia? Because these can be potentially very threatening or life-threatening considerations. We'll talk more about zoledronic acid to prevent skeletal-related events in the later slides. Some of the monitoring, we talked about the response criteria, but we also want to monitor the bone marrow function, looking for anemia, thrombocytopenia, which is cyclic and predictable with the bortezomib, as well as neuropathy, which can occur within 4 to 6 months of treatment. With a short course prior to stem cell transplant, Oscar should not experience any neuropathy, especially if it's given subcutaneously, but it's important to be aware that this is a risk. Patient education should focus on managing and monitoring of these side effects. It can be very overwhelming at diagnosis to be told you have myeloma. Now you have to take 3 drugs and preventative therapy. So open up the dialogue as a nurse and be aware of some of the side effects and kind of be their advocate and encourage them to take on that role and identify a caregiver as well. We mentioned transplantation. The International Myeloma Nurse Leadership Board has a wonderful supplement that was published just a few years ago. You'll have a copy of it on your jump drive, and it's also available online. It was published in CJON, an official journal of the Oncology Nursing Society, and it gives you some information as to what to expect and the uniqueness of transplant and myeloma. We typically do 1, but some people will have a tandem or 2 transplants as well, and that will all be covered in your supplement. As I mentioned earlier, survivorship is really, really important for multiple myeloma patients. Throughout this presentation, we'll be highlighting components of survivorship. Patients with myeloma are survivors from diagnosis and throughout. The Institute of Medicine recommends that a survivorship care plan be started for each survivor. Our Nurse Leadership Board put forth recommendations a few years ago, and we have also a CJON supplement based on that. But take-home points for you would be to have the patient have a record of care. What kind of regimens were they on? What kind of paraprotein do they have? Is it in the blood or the urine? Educate your patients as to monitoring, monthly blood tests or weekly blood tests, whatever is unique to them, and a follow-up plan. We want them to know what to expect in terms of imaging every year for skeletal survey. What other kind of health maintenance behaviors do they have to focus on, such as blood pressure and cholesterol screening as well?
So in summary, multiple myeloma is a cancer of the plasma cells, and that there are many, many new treatments now for patients with multiple myeloma. It is important that we get the patient's preferences for treatment, especially that we do not have one treatment that is better than the other. So definitely patient has a say about treatment choices. I will tell you that the most regretful patients are the patients who are not involved in the treatment decision making. So that is what we know. So it is important that from the very beginning we involve our patient. We must promote autonomy. We must advocate for our patient as nurses. And again, there are so many other roles that we can do in order to make sure that our patient will have the best outcome. And at the end of the day, that outcome is prolongation of life and quality of life. All right, thank you.